because of the recording and because of the sensitivity of issues like this, if you'd like to be confidential with any questions that you would like to ask, I simply ask that you send those through the chat to me, and I will be the only one to know who it's coming from. And in that case, there will be confidentiality about those questions. If you are not concerned about confidentiality and you'd like to ask questions, Dr. Cronyn has said that you can ask questions at any time. You can probably still do it through the chat, or if you want to explain it, just notify me. I'll be kind of moderating this. So today's topic is transgender healthcare, and it's such an important one today, not only because of the number of individuals who need these services, but also because of the large misunderstanding and lack of knowledge that many people, including healthcare providers, may have on this topic. Most of these services, if you can get them, are delivered in large cities. However, we are lucky that in the Pioneer Valley, we have access to professionals at Trans Health, even in our own backyard. Now, part of the people at Trans Health, part of that team is here today, and I'm happy to introduce Dr. Andrew Cronyn. He's a pediatrician and the former medical director at Trans Health in Northampton. As I said, he's a general pediatrician, educated and trained in New York City at Albert Einstein College of Medicine and the Associated University for Residency program. After that, he went to Arizona, Tucson, and practiced primary care. And while there, he recognized a real significant need for these kinds of transgender health. He subsequently founded a gender-affirming program. This was 10 years ago. He then came and moved to our area to help start up Trans Health in 2021. So Dr. Cronyn, thank you so much for joining us. We really appreciate your knowledge and your valuable time.
Thank you so much for having me. Let me move to my share screen. We're just adjusting this really quickly from the beginning. There it goes. Everything look okay there? Okay, good. So thank you so much for having me. I really, really appreciate it. This is something I kind of fell into doing and love. And so today I kind of just wanted to cover some pretty basic stuff on gender dysphoria in children and adolescents, and especially give us a chance to separate help from hype, because there is a lot out there. I have no relevant financial or non-financial relationships to disclose, and I will be discussing non-FDA approved uses of medications along the way. I'll let you know when I do that. So this is just we're going to do a little very basic review of terminology here. And because these are all things that get mixed together. I'm going to start down on the bottom right at assigned sex. So this is what early in my career, we would tell people when the baby was born. I think now assigned sex tends to happen in the womb most of the time. And anyone who hears about it, it automatically sets off a chain of events that can, start off at, I can't wait to see him with a baseball bat. I can't wait to see her, dancing at her wedding with dad, things like that, which is a lot of pressure to put on a baby before they're even born. It also can refer to chromosomal testing, and it is good to remember that sex at birth can be male, female, or intersex. And intersex is where kids will fall somewhere in between, or even somewhere where genitalia and chromosomes may not represent really much of anything that we would consider familiar. Gender expression is how someone presents their gender through clothing and mannerisms. One of the things I like to tell people is that for a long time, people, one of the parts of being transgender was considered what people did for a living. And it was long enough ago that we didn't have these at the time, but I have a picture of a woman truck driver being told she's trans because she's driving a truck. And now and gender expression is also something that really changes through time and in different societies. I don't think I could have imagined Harry Styles on the cover of a magazine in a dress with fingernail polish on when I was a kid. Um, Sexual and romantic orientation. This is who you're physically, romantically, and or emotionally attracted to. And this really has nothing to do with gender, but it gets lumped in under the whole LGBTQ umbrella, which is much more a political identity or social identity, and really doesn't have much to do with gender identity. Gender identity is what your internal sense tells you your gender is. So this is when I look in the mirror and I see myself and I say, yeah, this fits. I am a man. But it also can be the gender identity is when someone goes to sleep at night and the last thing they're thinking of, I really hope tomorrow morning I wake up a different gender than I am today. And then one more area is legal sex. This is what appears on your ID, social security card, passport, all sorts of things. Massachusetts does a pretty good job of letting people change their legal sex. When I was in Arizona, it was a very different story. There, people couldn't change their legal sex without surgery. And they couldn't get surgery if they were on the state Medicaid program, which meant a lot of people were stuck in this circle of continuously being misidentified because they couldn't afford to get surgery or they weren't allowed to. Just some words that you'll hear a lot when talking about gender identity and in transgender non-binary circles. An affirmed name is the name that someone uses. And honestly, a lot of us have affirmed names. My name is Andrew, but I use Drew. And that I would say is more a preferred name, whereas an affirmed name might be if I said, my name is Gretchen, and then people use that. They're affirming the identity that affirmed gender and pronouns are same thing. Affirming someone's pronouns is using the pronouns that they use. And again, this is where I put the note about preferred names. Misgendering is using a gender other than what someone wants to be identified as. If someone sees me and says, "Excuse me, ma'am, how are you doing?" Dead naming. A dead name is the act referring to a transgender non-binary person by a name they used prior to transitioning, which is typically their birth name. And this can be very challenging for families. I'm gonna have some ideas later on ways people can help make this easier for their kids. I say I'm always lucky because when people come to me to talk about this, I'm meeting the child with that name and that gender. And so it's much easier for me than for a parent who has gone through years of knowing someone a certain way. And in terms of names are very personal. People pick them out for all sorts of reasons that are meaningful to them. And nobody really just slaps a name on a kid. And so name changes can be a challenge a lot of the time. Gender identity, you'll also hear about cisgender. This is for someone whose gender identity matches their sex at birth. These are some famous cisgender people, The Rock and Emma someone. Gender identity, transgender. So this is an umbrella term for someone whose gender identity is different from their assigned sex at birth. So I was assigned male at birth, and if I identified as any other gender, that would be, strictly speaking, transgender. Now, a lot of people will use different classifications for themselves, and so you'll hear me saying this a lot today. It's a place to ask whether someone uses a term or not. I put some of the flags up here that people may see also. The first one, the pink and white and blue, is a transgender flag. The yellow, white, purple, black is the non-binary flag. The yellow flag with the purple circle is the intersex flag. And then on the right with the rainbow colors is the LGBTQ pride flag. And these are just one of many, many flags. Communities today tend to have many more flags than they did in the past. So transgender woman. This is going to usually be someone who was assigned male at birth and identifies as a woman. This may be someone famous, like Laverne Cox, who is an actress, and maybe someone not quite as famous, like the CEO of our organization. And that's the way to think of this is someone is transgender and they're identifying as a woman. That's why it would be transgender woman. Trans man, and some alternate terms, trans mask, transgender guy, just saying someone's a man. Usually uses he and him pronouns, and they may be a fitness model like Laith Ashley, and they may be a guy who he and his husband are having a baby together. And so variety there as well. Just a quick grammar note is that transgender is an adjective. And so we would say a transgender man, not a transgendered man. Transgender and non-binary people, not transgenders or non-binaries. We also wouldn't use it as a verb. We wouldn't say someone has transgendered someone. And it is an adjective. So non-binary. Now this is a category that is really in the last decade or so is where it has become more familiar to us as a term. And I look at this as evolution of language, because when I was a kid, there were definitely people around me who would fit somewhere on a non-binary scale of how their gender presented. I don't know if they identified that way. We didn't really have a word for it then, so they probably didn't. And so this is just a place where I'm really impressed with the young people today and how they are evolving language in front of us. You might hear other terms, and these are similar, but they're not equivalent. Again, asking people what they think of. Gender expansive, gender queer, gender fluid, bigender, agender. Most of these are kind of self-explanatory. Bigender tends to be if someone identifies as both male and female. Agender tends to be if they don't identify with any gender. They is the most common pronoun you will hear, but some people use ze, here, it. There are neopronouns. There are lots of pronouns out there. And again, it's a place where language is really evolving. Perhaps a bit faster in English-speaking countries or countries that do not designate gender as much on commonly used words. One thing that people mention is that it's not grammatically correct to use that as one person. And I will tell you it is actually. For example, I could say, yeah, you can invite your friend to the party, but make sure they don't eat all the dip like they did last time. And that's talking about one person. I don't know their gender. I can tell you that for a lot of gay and lesbian people, we learned to use they before we were out, because we didn't want to use a gender for the person we were going on a date with, but wanted to share that with friends, family, and coworkers. So it definitely can be used as a singular. The other thing to know is some people will use multiple pronouns. For example, she and they. And this doesn't mean you need to alternate them. It means both of them can be used. When I have patients come in with more than one pronoun, I ask if there's one they prefer. I have to tell you, most of the time, they will say either is okay. Sometimes one or the other will be preferred. And then every now and then you get the classic teenage response of, I like both of them. Please give me a 2-to-1 ratio of she to they, and I'll be counting, which is one of the reasons I love taking care of adolescent patients. They were kidding, by the way. So I wanted to go through a couple of scenarios here of different positions that people might find themselves in with their kids at different ages. And I really want to do this just so people have an idea of what does and doesn't happen. Some of that getting rid of the hype and the hyperbole out there. So the mother of a 4-year-old says, "My son thinks he's a girl. I'm not really surprised, but I don't know what to do." Um, I will, in these situations, say, "Oh, not really surprised. Tell me about that." Because oftentimes that will mean that the child plays with toys they didn't expect them to play with. They like colors they didn't expect them to. Um, I also have had families who have said, yeah, the before the ultrasound, or actually even before the baby was born, we thought we were having X and instead we had Y. So lots of reasons people might be surprised. In terms of not knowing what to do, hey, most doctors don't know what to do in this situation, and it was not covered in my parenting school, which I wish I'd had before becoming a parent. And so we don't know what to do. First thing people usually ask is this really possible? And I will tell you, before I started doing this, I really questioned it. And then someone pointed out to me something that I really hadn't internalized well. At the 3-year-old well child visit, we tend to ask people, the kids, we ask them, are you a boy or a girl? And part of the main reason we did that in the past was because we wanted to know about their language skills, hear what they would say, try to form a bond with them so we could hear the stories that a 3-year-old tells. But now we listen to it, and instead of, kind of laughing nervously and saying, "Oh, what's happening? Why is their language off here?" with the parents, and the parents saying, "Oh, they confuse that all the time," we might ask, like, "Hey, is this something that means something?" And so it's a place where parents will tell us this young that they have seen different signs that perhaps their child is not who they thought they were. And I have seen families who have noted problems specifically. I mean, 3 years old is when we're going to be doing toilet training, who had big issues with toilet training because someone either did or didn't want to stand. And did that mean something? Lots of times, no, sometimes, yes. So the diagnosis of gender dysphoria is kind of outdated. This is from the DSM, the Diagnostic Statistical Manual we use currently. And some of these things, I think there's confusion by the people who wrote these about the difference between gender presentation, gender expression, and gender identity. So, for example, strong preference for wearing clothes typical of the opposite gender. Um, and what does that mean differently also for people assigned male and people assigned female? Maybe strong preference for toys, games, or activities stereotypically used or engaged in by the other gender. I hope we've moved past a lot of people thinking that games and activities have to be related to a certain gender, but really that is something that is definitely out there and is in the DSM. Um, Strong dislike of sexual anatomy. And that is something you don't necessarily see. Um, One of the things I tell a lot of parents who say, wow, I really didn't see a lot early on that would show this, but I also let my kid wear what they want, do what they want, and cut their hair like they want. And I say, that is wonderful that you just followed your kid's lead and showed them they were loved and supported. Um, it makes my job interesting because I look at this list and it's hard to say, what is the opposite gender in it? What are the opposite gender's clothes in a family? One of the ones that I abbreviated here is actually I find really funny is that in boys, a tendency to avoid rough and tumble play, which I think is one of those phrases that probably deserves to be put into history. So this is what I really look at is identifying gender incongruence. So this is seeing that someone's gender doesn't fit with what their body or their assigned gender is telling me. And these are phrases you'll hear pediatricians use. Someone is insistent, consistent, persistent. Um, and I put a little asterisk on each of those. because in terms of insistent, um, if someone is not supported in their gender identity and they're 4 years old, they are probably not going to insist for very long if everyone around is telling them that they're wrong. And so we need to look at sort of the bigger picture of their life and where things are happening. Consistent is also an interesting term because there are very few things through childhood that remain consistent. And it's one of the exciting things about being a pediatrician. But here it tends to be consistent in terms of not identifying with the gender identity they were assigned at birth. Now, that might be many different gender identities that they have. I will have kids come in and say, or they'll say, first I was non-binary, then I thought I was gender fluid, then I really, really realized I was a guy, and that kind of felt right, and that's what's going on. And I'll say, yeah, and it sounds like so consistently over time, you were saying, I am not a girl. And then persistent. So persistence means over time. Um, and this can also be a challenge for someone if they aren't affirmed in their gender to persist in expressing that gender or even feeling it. But we like to see kids affirmed in their gender for at least 6 months, usually 12 months before we do any sort of irreversible interventions. In fact, the reality is, I have been doing this a while. I have seen a total of 2 patients in the last 10, 12 years who have come in with less than 6 months to a year of having been affirming their gender. It just takes that long to get into people. It also takes that long for somebody to affirm their own gender. We call that the coming in process before they come out. Different ages, we do different things. We know different things about people's gender identity. Very young children are the ones starting to have gender awareness. Before puberty, kids are navigating their social lives. They're starting to learn about those connections outside of family. They hit puberty. They are having pubertal changes in their bodies and their emotions and their connections to other people. Their identities are starting to form. And then in adolescence is where they're really laying the groundwork for adulthood. And their role models be maybe more outside of the home. They may be harder for us as parents to talk to. But these are very different considerations of where gender fits at different ages. And so that's why that 4-year-old I mentioned before, so a 10-year-old, little bit older. My daughter just told me they're non-binary. I'm supportive of them, but I'm not ready for medicines or surgery. And I will typically say here, whew, that's good. Because although you will see stuff in the media talking about irreversible medicines and surgery at 10 years old, that is not something that actually happens. So looking at where we have medical interventions by age, the main thing, in fact, almost the only thing I do in my office with kids who haven't started puberty yet is supportive and accepting care, using their name, using their pronouns, making sure they're not being bullied, talking to them about how supported they feel, and the usual, making sure they don't have, ear infections and that they're gaining weight okay. From those young ages up until they get to puberty, parents may be concerned about finding that gender affirming care, setting legal documents up, setting school support up, and finding community organizations where they can meet other parents. But again, all of these things are 100% reversible. Other things people may be doing there are things like hair, makeup, clothing. So lots of different things, lots of things that are They are very big to kids. They can be terrifying for us as parents because this isn't something we learned about. But just realize all of it is reversible. Then we're going to talk a little bit about the medical stuff coming up, but about pausing puberty, which is also 100% reversible. Then a little bit about hormones. I'm not really going to talk about surgery because I don't really refer very many minors to consultations with surgeons. So when we put puberty on pause, couple different medicines. One's a shot, one's a thing that goes under the arm, sort of like Nexplanon is the most common that people have heard of, a birth control. Now, these medicines have been used since the 1980s for central precocious puberty. So this is your kid starts going into puberty at 4 years old. Obviously, you don't want that for physical, social, and mental health reasons. And so this is a medicine that has been used since the 80s for that. Also used in endometriosis, prostate cancer, part of a treatment for infertility sometimes. It is not approved for puberty suppression in transgender patients. That doesn't mean it hasn't been researched. It doesn't mean there isn't a lot of evidence. What it means is nobody has paid to file an application with the FDA or done studies in the way that the FDA requires. Those would need to come from a drug company. And I highly doubt that in the current political climate that the drug companies will be doing anything to get FDA approval. Now, remember, these medicines are fully reversible, whereas puberty is a one-way street. I will say that is not my line there, but I do like that expression. It comes from the head of the transgender program at Boston Medical Center. Just to give you an idea, the implant in the skin, it's tiny. It lasts about 2 to 3 years, and you can even put it in the office. Most kids don't even need anesthesia. They just get a local anesthetic and it's put in. Takes about 30 seconds plus the 15 or 20 minutes to get someone relaxed and their arm numb and all the other things we have to do. Now, do these work? I feel very confident in saying at this point that we have probably more research on mental health than anything else. We know that pausing puberty helps for kids with gender dysphoria or kids who are questioning their gender identity. Basically, it lets them relax and not think about irreversible changes coming in puberty. There's a protocol done in Amsterdam that people talk about called the Dutch protocol. It's followed kids over years. The other long-term study I really like is a researcher, Christina Olson, is a psychologist currently at Princeton, previously at University of Washington. And she's been following a group of kids, their siblings, and age-matched controls over time, and really shows that trans kids who get puberty blockers, their mental health is at least as good as others, and than the kids in those other categories, and in some cases better, which actually doesn't surprise me because I think that if a child can tell their parent that their parent is wrong about their gender, they're probably going to have a much easier time telling their parent when they've broken up with their first boyfriend or failed a test. Physically, we have decades of research with central precocious puberty. The challenge with that is those kids are on the blockers for much longer. It can be 7, 8, 9 years, whereas trans kids are usually on them no more than 2 to 3 years. But we do know what the risks are. Bone health is something definitely seen when they're used for that long extended period in central precocious puberty. But when we look at it in trans kids only on it 2 to 3 years, it appears that any decrease in bone density actually improves when they either stop blockers and go through their birth puberty or they go on to puberty hormones from the outside. In terms of fertility considerations, this is an area where I feel like some folks kind of play with the definitions here. Both people who agree with them and disagree. Fertility is a consideration. The blockers do not make someone infertile. If someone is on the puberty blockers, say they're 10, 11 years old, and then 3 years later, they decide to stop them, their body will start puberty right where it was, will not affect fertility. However, if someone is on them and then uses cross-sex hormones, then their gonads are not going to mature. And with the technology we have right now, they would be biologically infertile. This is, I have to say, one of the most difficult conversations for me to have. And it is a very personal decision for families and their children. What I can say is we need to be lobbying insurance companies to be covering fertility, not only for these kids, but also kids with things like childhood cancers. And we also need to realize there are new technologies coming up. And the thing I heard once from a mom I was talking to was, if that is an issue for my son later on in his life, I will tell him we did what we did at the time. We all agreed on it, and it was between him and I and our God. It is a difficult decision. I will say, because we're constantly reviewing if someone wants to stay on or whether they want to go through their internal puberty, as I had said, if they stop, then their fertility will come back. In addition, it means we're not making that decision at 10 years old, but it may be something at 13 years old when hopefully we've had a lot of discussions, therapy around sort of the long-term implications for kids. Benefits physically: decrease the need for future surgeries and other treatments. If someone is on puberty blockers, they don't develop breasts, they will not need mastectomies later. Now, some people don't have surgery anyway, but it decreases the need in the people who need it. Avoids the unhappiness and trauma of unwanted puberty, and gives families more time to come to agreement on whether or not to start gender-affirming hormone therapy. So not only is it giving the kids a chance to take a deep breath, it gives their parents a chance to take a deep breath. New York Times, November 2022. This is the article that people are seeing when they look at bone density. It's called "They Pause Puberty, but Is There a Cost?" The New York Times actually it has had a string of very negative articles about transgender people. And I have to say, it's been something that goes back quite a ways with different topics. Before I went to medical school, I was in public relations, and I was working on an estrogen patch. And at that time, the New York Times really was pushing the idea that postmenopausal estrogen led to breast cancer in large numbers. It looks more and more like it was probably the forms of estrogen that were being used, and that some of those studies really are pretty dubious. After breast cancer, the next one was ADHD. The New York Times had a string of articles about the problems with ADHD treatments, and this is just the new thing. But in this article, specific things I can point to: the bone expert is an adult endocrinologist, never seen kids with gender dysphoria, hadn't really used puberty blockers. Epidemiologist who is quoted in the study actually studies heart disease in adults. There were 3 cases of osteoporosis, no context, although one of them context has come out. This was a child in Sweden who had vertebral fractures about 2 months after starting on puberty blockers. 2 months is not enough time for a reduction in bone density. So this child most likely had an underlying problem at the beginning, and the blockers were not part of it. The studies that they quoted are really poorly designed. We're seeing kids compared to adult bone density when they're young, also having a trans boy having his bone density compared to a cisgender boy means we're comparing someone whose bone density potential was lower to start with than the person they're being compared to. So pretty poorly designed. There also is a big thing made in these articles and others about how Europe is cutting off gender affirming care in kids. reality, England is the one people point to the most. It is not that it is now considered experimental, it's that they decided to study youth getting puberty blockers because they have a national healthcare system. They can study everyone. And it's great to see a large population being studied. In addition, there was talk that they had closed their gender clinics. Actually, they decentralized care and started smaller clinics and moving into primary care around the country. So these stories I take with a grain of salt. I like to look things up. Third one.
Andrew, Drew,
Yeah,
can I interrupt a couple
definitely.
questions?
Yes.
The first one, I want to make sure that I'm not sure I understand the bone density issues.
Yeah.
Are those does it matter which gender you have at the moment? In other words, are we talking about concerns about bone density for both transgender male and transgender females? Is that correct?
Great question. If it was a long time on them, we would be concerned about both. Most of I'm more concerned about transgender females because I am more concerned with teenage girls having bone density issues. And I don't think it matters to me whether they're cis or trans. And so if they're starting at a slightly decreased bone density, I am concerned there and am going to be making sure I'm supplementing and so watching that closer. Trans boys, I'm not as concerned because testosterone does a better job of laying the groundwork and protecting bone density as well. Interestingly, most of the studies have been done in trans boys, these poorly designed studies, and the results don't make scientific sense. And then you start reading the studies and realize why.
Thank you. And another question, in your practice and or in the literature, how many of your patients in general start puberty blocking agents and then end up deciding that that is not the right fit, the right thing to do?
So it is, my understanding from the big centers is the numbers about somewhere between 2 and 5%. Which actually, just from I remember we used to say in my surgery rotations as a med student that if you were getting if you were getting 30% of appendixes that you opened were healthy, you weren't doing enough appendectomies. So when I hear 3 to 5%, I'm actually more concerned that we're missing a lot of kids than that we're giving medicines to kids who don't need them. In my experience, I have had, it probably fits in about the 2 or 3% because I'm struggling to think of names. And so it is it's a little challenging for me to get exact numbers, but I think probably somewhere between that 2 or 3 to 5%.
Thank you. Very small, or small, I would say.
Yes, very small. And I'm going to talk a little bit more down the road about the hormones as well in that.
Thanks.
Any others that were there?
That's good. Thanks.
So this is a scenario that I saw on Twitter. Basically, a 13-year-old goes to Planned Parenthood. Always Planned Parenthood is always who they bring up, and says, over the past few weeks, I've realized I am transgender. My family doesn't believe me. Can you help me get hormones? There's so many things wrong in this scenario that tell me it didn't happen. First of all, 13-year-olds need consent of parent or guardian to have any hormone or blocker treatment. The things that we can do for a 13-year-old trans kid without consent of parents are exactly the same as they are for a 13-year-old cisgender kid. And so it's something where there are very, very few interventions that can be done without consent of parents. This is definitely one of them. In fact, we're actually limited a bit more, is that in a lot of places, we need consent of both parents, even if the parents are divorced. It will need to be consent from anyone who has medical decision-making authority. Also, a few weeks is not gender dysphoria. As I mentioned, Previously, it's at least 6 months, usually over 12. And then one of the things I like people to think about of a 13-year-old getting hormones is, when does puberty usually start in someone who's assigned male at birth? Maybe 13, probably a little closer to 14. And so that would mean that someone assigned female really wouldn't be getting testosterone till at least 14ish. Assigned females, now we're seeing kids very, very young starting estrogen-based puberty now, cisgender kids. And so we could say, yeah, then maybe trans kids, we should be starting them on hormones at 9 or 10 years old. I don't think anyone actually says that. I don't believe in it. None of the colleagues I've talked to believe in it. And we don't we don't start hormones until after someone has had the beginnings of their own internal puberty. So there's a lot going on here that is a little bit confusing to me. And I don't believe, even though it was on Twitter or X. We also recommend therapy for kids. Honestly, in this day and age, I recommend therapy for everyone. The world's a rough place. When they're in therapy, though, it's not to prove what their gender identity is, but it's really to determine their understanding of what that gender identity is. The differences between gender identity, sexual orientation, gender presentation, talking about understanding the treatment, finding out what their body goals are, sadly promoting resilience. Although, I mean, resilience is important. I feel like having trans kids having to be resilient is the thing that makes me sad. Helping them complete some developmental milestones and work on them. And what do I mean by that? I mean that if you are 12 years old and you're trans and you've been performing a gender that you don't feel for a long time, your brain is wasting time on that it could be doing thinking about what sort of a person you are, what your values are, things like that, which are more typical teenage milestones. We do not require psychotherapy in our practice. Some places do. But as I said, we do recommend it for a lot of these reasons. Hormone therapy. So things we think about here, and this is just because we're talking about teens here. What is the cost of not starting? For a trans girl, the cost of not starting can be a low voice, a beard. For a trans boy, actually, that would be cost of not starting blockers. It could be not presenting as themselves in the teen years, which is a time when presentation is really important. It can affect self-image and self-esteem. There are discussions over when to start. The original guideline said 16, because that was the age of consent in the Netherlands and where the studies were done. Initially in the US, they were given at 18. Started over time realizing that really the time that other kids are starting puberty is probably important. Sometimes just how mature someone is. So we may be starting hormones later than their peers or having their internal hormones start, just because they don't really seem to have a good focus of their maturity. Concerns we have here are the consent issues, irreversibility, and we ask a lot of questions about fertility. Just to let you know, the irreversible effects of estrogen are breast growth, effects on fertility, and fat redistribution. The reversible effects, these are all the things you would expect of a typical internal female puberty. The reason I have asterisks on a couple of these is that effects on fertility, there appear to be some people who go on estrogen and it is toxic to their testicular production of sperm. But that number seems to be substantially lower than we thought at first. And so fertility is not quite the consideration we once thought. Fat redistribution also, People say that the estrogen going into the hips may not reverse. I don't really know that we can say that. So the big irreversible thing from estrogen is breast growth. I also put a little asterisk on reversible effects on sexual function. Reality is that hormone therapy at the correct levels should not have an effect on sexual function. Unfortunately, the medical system has not done a lot to support female people with estrogen in their bodies, in their sex lives until fairly modern times. And so a lot of times we'll hear people had effects on their sexual function. They were told that's just part of being on estrogen, where the reality was perhaps they have a low testosterone level. So again, looking at perspectives on things. With testosterone, there is more that's irreversible. Losing hair, and most people don't lose their hair until older. But occasionally there are teens who will start losing their hair, both cisgender and transgender. I always tell people, fortunately, as the population ages, we're getting more and more ways to treat baldness. Deepening of voice is an irreversible change. Facial and body hair growth, irreversible, although become a bit finer over time. And then clitoral enlargement, growth of the clitoris, or what's called bottom growth. And then you'll see on the reversible changes, it's exactly what you would expect to see in any teenage boy. Oily skin, acne. I could have put in changes in body odor, increased muscle mass, increased libido. One thing we do see in trans boys on testosterone is they can have some atrophy of their vaginal lining, which can cause pain during sex or masturbation. It also can cause pelvic pain, but that's something that's easily reversible by giving them a little bit of topical estrogen. So you can see there are more things that are irreversible with testosterone. And a young adult scenario.
Drew, can I ask another question?
Yeah.
And maybe you'll get into this. Can you give us an idea of how these hormone replacements are actually administered? Are we talking about injections? Are we talking about pills? How often and such?
That's a great question. I really should have that in there. Estrogen, pills, patches, or shots are the three choices. Patches we'll use in anyone who smokes cigarettes or who has a family blood hypercoagulation problem, so their body forms blood clots too easily, or anyone who's had a blood clot, because the patches have the lowest blood clot risk, which is again, marginally increased risk in people on estrogen, although we're finding more and more that's the form of estrogen, which is natural versus artificial. Ethinyl estradiol was the estrogen a lot of people are getting for years, and that causes clots, whereas estrase, which is what we use, tends not to. That's patches. Shots are thought by some to work faster. And so actually in younger teens, we don't tend to start this because we don't want puberty to go super fast. And then the pills are easy. People dissolve them under their tongue. It gets absorbed into the bloodstream. It's great. And it's a pill. They take twice a day. The shots are once a week. The patches are one patch are actually new patches get put on twice a week. So a lot of it depends on kind of what someone's goals are, what they feel like they can remember to do. With testosterone, initial choices are either shots or gel. The gel goes on once a day. Upside, it's a once a day gel. You put it on, you don't need to have a shot. Downside with gel, it can take a little bit longer. Again, not necessarily a problem in a teen. But it also is something they need to wash their hands really well. I tell them they don't want to share their testosterone with mom and have her grow a mustache because she will not be happy. The shots, again, they're weekly, and they are typically what folks start on, but they're shots. And at this age, people may have had a lot of shot experience with vaccines and not really know whether they can handle doing shots even weekly at home. in which case we'll talk to them about gels. Now, the reason I say to start, there are many options other than these for testosterone later on. There's a nose spray, there's an underarm testosterone gel, there's a newly invented pill. There are pellets that go under the skin. There were patches. They seem to be off the market. It doesn't surprise me because everyone who I knew on them got allergic to them. But as you can see, long term, many more options in the testosterone arena than in the estrogen arena. And I will leave people to their own conclusions of what that says more about the pharmaceutical industry than anything else. But those are the forms. So this is the scene, it's a scenario that started getting big a couple of years ago. 19-year-old, she thinks she's a boy. I know this is just because all her friends in college are trans and non-binary and she thinks it's cool. So this was something called rapid onset gender dysphoria. It was a study of parents' impressions of their children's transition. These parents were recruited on anti-transgender websites, and they were all from these websites, and no one asked the kids about whether or not things were rapid onset. There's a question as to whether this had something to do with I don't know, the more assigned female versus male became part of this argument as well. I will tell you, in a lot of centers around the country, there are more people assigned female at birth coming out as either non-binary or transmasculine than people assigned male. I will also tell you that in our practice, we are close to an even number. And that, I believe, is because we have a trans woman leading our organization. I was telling a friend of mine who runs a clinic about this, and she said, wait a second, that's what my numbers are as well, is about 50-50. And I said, yes, and you're a woman running that center. And so it is riskier to be trans feminine in a lot of ways. And so knowing that there's going to be safety is really important. And so what I actually think is that in a lot of these places where we're saying, wow, there are so many transmasculine and non-binary people, and by the way, so many actually only comes out to a few percentage points, and that we're actually missing people assigned male at birth. So just so people know, it is a myth. It's not a recognized diagnosis. Oh, the thing about it being new and trendy is interesting. So the World Professional Association for Transgender Health Guidelines from 2011 cited studies in 1988 and 1998 talking about how a lot of adults and adolescents presenting with gender dysphoria did not report a history of childhood gender nonconforming behaviors. This isn't new. This isn't trendy. This is something that's been going along probably since history started. In some cultures, definitely since history started. The other thing I like to point out, so besides pointing out that it really is just a few percentage points of kids who are trans and non-binary, a couple other things to look at. When we say, oh my gosh, everyone's coming out, look at the history of left-handedness. My grandfather was left-handed. He was in the before 1920, and he was hit with a ruler on the back of his hand to make him not be left-handed. I'm left-handed. No one ever did that. My biggest problem was pencils that smeared and people who didn't know how to teach me how to write cursive. But more people were identified because it became acceptable. It wasn't that more people became left-handed because it became socially acceptable. The other thing, just to let people know, in terms of identification as transgender and non-binary. So I will hear people say, my kid's in a Girl Scout troop and half of them have come out as non-binary. First of all, I say, wow, that is a really good Girl Scout troop for these people to be supporting each other in. Because frankly, I have a lot of kids coming in to see me from the Berkshires who are the only kid in their whole town as far as they know. And so it may just be we've got a more supportive environment. Second thing is just because someone's identity is transgender or non-binary, that does not mean that they necessarily are getting any sort of hormonal, medical, or surgical intervention. And I think that's something that really needs to be noted. There are a lot of people, especially who identify as non-binary, who it is a non-identification with their gender, their sex assigned at birth, rather than wanting to gain characteristics of the sex they weren't assigned at birth. So they won't start hormones and surgery. Some people do, some people don't. But it's really important to know that when you hear these things about large numbers of kids in different places who are coming out. The other thing to think about is that people find people around them who will support them. And so if one person comes out, they're very likely to find others. The other thing we often hear about is transition-related regret. This is something that is actually not very common. There was a study at one point that said 80% of children will stop identifying as transgender. This is a study that lumped together some kids who probably did have gender dysphoria, a lot of people who might have socially but not medically transitioned, and then people who are simply exploring gender diversity. The study was done in Canada at a center that purported to help people not be transgender. And so with universal health care and the government paying for this healthcare, it meant that people would go in when their little boy put on a dress at a party and they were worried that he might become trans. And so those kids didn't desist, but they didn't even start. Interestingly, in Europe, the Russian Federation has paid for a huge amount of the funding in the anti-gender movement in order to seed to create some disconnection in society. So the numbers of people who both detransition and regret, very low. I mean, it's under 1% in most studies. You'll see the US survey, 8% had some form of detransition. I'll explain that in just a moment. And yeah, in Sweden, there's a study on surgeries where 2% of people regretted gender affirming surgery. Interestingly, there's about a 7% regret of any knee surgery that is done. Why do people detransition then? By detransition, we're saying stop hormones, return to their sex assigned at birth. 90%, probably even more than that, is social pressures. They don't have support, they can't get a job, they're being harassed. And so they say, I am going to live with this privately in my house. I am not going to bring it out in public. And that can be very difficult. There are all sorts of stressors involved with that. Sometimes it's financial considerations. I will tell you, I had patients I saw in Arizona who would not do transition or would have to stop their transitions when they lost their insurance and weren't able to get meds paid for. And maybe they further explore their gender identity. There are quite a few of my patients who I see will say, I know that I am trans masculine or I am trans feminine, and this is what I'm doing. And as they go along in years, they start feeling like, maybe I'm not exactly on this end of a spectrum or this end of a spectrum. I'm somewhere out here. And so their plans stay the same. Their pictures of themselves stay the same. Their gender identity might become one of the non-binary genders. Also, other medical concerns develop. If someone develops some form of cancer and needs to come off, then that would be example of a medical concern. It is only certain cancers where that would be the case. And finally, people who've reached their goals. So remember all those things with testosterone that are irreversible. The hair, the voice change. Those are things that some people, that's really the big parts they want for their gender expression. And so they'll stop because they don't want to be on a medicine. And that is just fine. We don't want anyone to be on medicine that they do not feel they need to be on. So out of this, the numbers in that US survey, it turned out that about 0.4% were the ones who really changed because transition wasn't right for them. So it's a very small number. When I say the 5% there is because it's 5% of a small percentage, so it comes out to 0.4% of the total. Last, I want to run through really quickly some things that people can do at home, because I think this is what's really important. When your child comes out to you, they will have been thinking about this for a long time. It may be the first time you've considered it. And so the way a lot of parents will describe that is, my child was already on the train and I wasn't even in the station yet. And so I wasn't ready to support everything medically, surgically, but I want to show them I can support them. So the most important thing is this sentences that I wrote here. I love you. I'm honored you would tell me this. I'm so glad you feel safe coming to me. Or your own version that doesn't sound like it came out of a book. But these are the things kids want to hear about almost anything in their lives. I love you. I'm honored you would tell me. I'm so glad you feel safe. It's what we all want for our kids. But what other things can we do? Well, first, I'd like to say the things that aren't okay. We can't process our emotions with our child. A lot of parents, when they first hear their kid is trans, will go through a grieving process for the child they expected, and that's fine. But that child is not grieving. They are happy. They are excited to have come out. They're thrilled to have been able to tell you. And so the grieving process is something that needs to be done separately. It's not okay to out our children without their permission. We don't tell I'm will say that it's something where you telling another parent who doesn't know, you need to ask the kids first. And the last thing is, it's not okay to do nothing at all. We can't just ignore this. Kids cannot drop something on us and we say, all right, and then never talk about it again. So what are the things we can do? Using name and pronouns. So pronouns are more than pronouns, they're identity. So we want to make sure we're using the pronouns that someone wants. Practice them, write them down, put them on a post-it note so you remember whatever it takes so that you can use those. Use them when you think they're listening, and I would say more importantly, use them when you don't think they're listening. Talking on the phone, having them over here, you say something about their son when that's how they're identifying. I will have kids tell me that was the first moment in their life that they felt true gender euphoria or happiness with their gender. I'm going to say something about names, though, also. It's hard to let go of a birth name. I realize that. I agonized over my child's name for a very long time. But it is okay to discuss. I had a parent who came to me, their 5-year-old wanted to be called Deadpool. She said, I cannot agree with this, and I think I'm being a bad person. And I said, no, you're not. On the other hand, I have kids with beautiful stories about having selected a name, their parents saying, hey, if you were going to have been the other sex when you were born, this was the name you were going to use. And the kids hearing it and saying, wow, that feels like my name, and then using it. And that I find beautiful. You're going to make mistakes. What we do, so the kid realizes you've made a mistake, they say, ouch, you say, oops, and move on with it and try harder the next time. It can take some time, but definitely keep making progress. In some families, we use something that's sort of the equivalent of the swear jar that's in TV and movies. Every time someone is misgendered or misnamed, a quarter, $1 goes into that jar. Go shopping if they want to. Underwear, bras, binders, breast prosthetics, packers, which is some people want to have something that makes it look as though their underwear has a penis in it. STP, something where they can stand to pee. A gaff is something someone uses to tuck their testicles. It's a type of underwear that works that way. But honestly, going shopping for clothing with them, just regular everyday clothing, can be so affirming for kids. If they tell you they're embarrassed that they might meet up with a friend and they don't want their friends to know, go somewhere else. Go drive an hour and go to a store there. Hair and makeup. There was this beautiful ad a couple years ago from, I believe it was Bic Razors, of a father teaching his trans son how to shave. I've had kids tell me about the incredible feeling they had when their dads did that. I have also had kids whose moms have taught them how to do hair and makeup. Yes, those are stereotypical things that people do with their kids, but they are stereotypes that can make kids feel really, really good if it's an option. I've had parents ask me, well, now my 8-year-old wants to wear lipstick. No, you don't have to let your 8-year-old wear lipstick. If you didn't let your 8-year-old cis daughter wear lipstick, you don't have to let your 8-year-old trans daughter wear lipstick. Maybe they want to try it at home. Maybe they want to do makeup that way. That is just fine. That's probably what you did with your cis daughter as well. But things like haircuts, remember hair grows out if they cut their hair short. And if it's long, it can be cut. Meet other parents. Most important thing, you don't want to do this alone. Even if you are 10,000% behind your kid and you know everything about them, other parents will tell you the things you'll want to know in 2 years. And that will make your journey so much easier. These parents are also the place where you can process information and those feelings because very likely they've had the same feelings. Locally, Translate Gender is the organization that has some of the best family support. Online, there's Trans Families, Trans Family SOS. Actually, I'll share this, the resource guide as well, because it has this. There's also some specific Facebook groups. Most of them have the word mama in front of them because it is mostly mothers in these groups. We're going to go back to gender stereotypes here. Dads tend to process things differently. So there are fathers only groups that are out there. There's going to be a really cool short movie coming up on Netflix soon called The Dads that I highly recommend. And then the last one I have here is called Freed Hearts. This is for religious families to get support within their religious community. It's primarily evangelical and Southern Baptist, but they now have things on their website for many different religions. Use your own pronouns. If you are saying to your friends when they come over, hi, I'm Drew, my pronouns are he, him, your child will notice. They will notice that you're using pronouns and are affirming them. Attend events. Let your kids meet other trans people. Let you meet other trans people. There's pride events. There's a transgender pride in Boston that's huge. First Night in Boston is a conference that has trans adults, trans children. Gender Spectrum has an amazing conference that is for trans children and their families. And there are always different ones out there. So attend these big events. Get to know trans adults because it can help you really understand what the community is that your child is coming into and be able to help lay groundwork for a successful future. Help your child build their own community. And this is saying, again, don't force on them, but, mention that perhaps knowing other trans kids could make things easier. So, I've got these 2 kids that I go to school with. You know what? Sometimes knowing some kids you don't already know is good because they'll bring in totally outside perspectives. So that can be good. We have Translate Gender and Gen Q are in Northampton. Gen Q is also in Greenfield, House of Colors in Holyoke. Our organization, Trans Health, actually has support groups. The age starts at 13. And they're broken up by age. Translate Gender has them even younger. There's also PFLAG in the area, and I believe going out even into the Berkshires has some supports as well. And then sending nonverbal signals of support. Stickers, put stickers on things if you're at the sticker age with your kid that show, transgender flags on them, for example. Watch different movies, watch TV, show examples. Maybe that watching I Am Jazz is helpful. It may be that reading a book, the I Am Jazz book is helpful. There are many books out there. They are easily found either on Amazon or on the Welcoming Schools website. And then leave your work lying around. So if you are reading, this is an example of a book that I loved because it helped me see teen perspectives called Being Magenta. It's essays by teenagers. If you read this, leave it lying around. Let them find it and see that you aren't doing nothing, that you are doing something. That yes, you may not be quite there yet for medicine or surgery, but you are doing something. and they will notice and they will love you for that and feel supported. And this is what we do in our office with our lots of nonverbal signals. We have art, we have flags, we have t-shirts. More importantly, I think, is that we have a staff with a lot of transgender and non-binary people on it. And I will never forget the first time that I had a old trans girl who I brought upstairs to meet our CEO, and the look she got on her face meeting a successful trans woman running a company. It was great. And that, I think, is good. I hope we still have, all right, so we have a little time for questions.
We have some time. Well, thank you very much. That was a wonderful summary and discussion about things that I learned from as well.
Oh,
and
great.
I hope those attending did too. I'm sure they did. I'm going to ask if anybody has any questions. Why don't you can put it in the chat to everyone, or you can put it specifically to me. We won't use names here. And please feel free to ask anything that's on your mind. I'll give you a minute to do that. I wanted to ask a question about the psychotherapy aspects of treatment. You mentioned that you don't feel that that it's required, I think is the word. Right. But I think that in my practice, a lot of kids, as you said, have psychotherapists and need support for whatever's going on. And I find that kids who are transgender maybe even have more pressures on them or more problems that they would benefit from talking to a psychotherapist about. And we do know that there's a higher risk of suicidality in transgender people. I'm not sure exactly what that's all about, but the question is, how what does psychotherapy look like in general for these kinds of patients, or is it no different than anything else?
Actually, one thing just to put in there really quickly on the suicidality. We know that suicidality, if you are affirmed, so your name and pronouns are used in at least 2 places. So for example, home and school, your suicide risk is actually lower than the average cisgender teenager. It's kind of remarkable. Now, what does psychotherapy look like? A lot of it is, what I tell families is, because it's very hard to find people who are specifically, seeing lots and lots of transgender people. We have therapists, they seem to become overbooked the instant that they open their panels. So I want a therapist who is really good at basic therapy, anxiety, depression, hopes, fears, resilience, all that stuff. And they know that not everything is gender identity for a trans kid. But on the other hand, sometimes gender identity is the most important thing they need to talk about. And what do I mean by that? I mean, I have kids who come in, one of my first patients, she actually transitioned her gender presentation over the course of 2 years with a therapist who she was seeing for anger issues, and he never commented on it. And it was baffling to me how someone could do that. On the other hand, I have had patients who have gone to someone who they're like, listen, my real issue is I have social anxiety, and all the therapist wants to talk about is their gender identity. And so a lot of it is just learning to follow their lead, learning what the words are they use to describe things. When we have kids who are specifically talking about their gender identity, it tends to be around realistic expectations, and realistic fears, and things like embodiment goals, what someone wants to look like in the future, thinking about future fertility. So all sorts of things there that I would say the reason we don't require therapy is, number one, access issues for therapy in general are horrible everywhere. And number two, We don't want to use it as sort of a club to make someone do something. I will tell you the vast majority of my patients either are in therapy or are looking for a therapist. Very few of those is it because of their gender identity. But we know that our kids, even in this area, are bullied more than in other areas. And so dealing with bullying is a big thing when that causes anxiety, and then kids want therapy.
Thank you. Again, I'll ask people if they feel free to write or say something. In the meantime, I have another comment and question, if that's all right.
Awesome.
Oh, wait. I will let somebody else come in. I see that there is a question that somebody has. I'm just going to read it and see if what your thoughts are. I'm going to read it out loud. My 15-year-old was assigned female at birth and identifies as non-binary. They have only been out to us since May, but are asking about microdosing testosterone. We are a little unclear about the differences between microdosing and regular hormone therapy. We are also wondering about the time frame to this sort of thing. They would like to see a doctor ASAP. If we were waiting 12 months, at what point would we need to start them with a doctor? In other words, does it take a long time to get microdosing started?
So, great question. So microdosing is a term I don't particularly love, mostly because it comes from a very different world than the medical world. It's basically low dose testosterone. And the thing, different people with different goals will aim for different levels. Testosterone, a normal testosterone level is somewhere between 200 and 1,000. That is a huge number in lab results. And the reason that 200 is the lowest is because that's about where we need to be to protect bone density and increase bone density. So microdosing for someone could be keeping their levels right around that 200 or 300. And so that is really how I take it. We do a lot of talking about what people's, their goals are before we decide what to do. Because often people will hear a term and it means one thing to them and one thing to someone else. So microdosing for me might be, I want that low level. Microdosing for someone else might be, I want changes to be slower. So we might talk about using a different form of testosterone, for example. Now, in terms of the time involved, so this is the sort of person I would love to see sooner rather than later, so we can start talking about things. There also are other things we can do. For example, someone 15 years old, assigned female at birth, we can stop their periods. That is something that is done either, hormones, IUDs are options there, but we can stop people's periods. And that can provide an incredible sense of relief. We also can talk about speech therapy. There are free apps online. There's a local speech therapist who is absolutely wonderful. We can talk about things like binders. We can introduce you to other kids who can talk about things they do when they feel dysphoric. So there are lots of things we can do that fit in that realm of nothing. And so starting that stuff is really important. Now, the other thing is when we talk about it in terms of the time, is looking at, so it came out in May. So we're not even at 6 months of coming out, but we talk a lot about people's histories. What was going on before that? Are there things from childhood you think about? Are there things from childhood they think about? Do you remember them getting a pixie haircut when they were 7 years old and telling you it was the best haircut they'd ever had in their life? And was it someone who was a tomboy? We don't unfortunately have an equivalent term for people assigned male at birth. But those are some of the things we talk about, is trying to pull out some of those, like, what were things where perhaps this was going on longer. I look at one of the big things in the modern age is what avatars people use in their video games. It's actually a question that I very often will see teenagers have a light come on in their head when I ask them, like, when was your first feminine avatar they had? And they're like, oh, I've always had a girl as an avatar. And they think that other people are doing that as well. Most cisgender boys are not picking female avatars to try out a different look and different clothing online. In fact, the number of kids I see who will say, like, yeah, I used to ask, when am I going to be a boy? And it wasn't until I asked myself that, it wasn't until I asked my sister and she said, wait, what? That I realized it wasn't something everyone was thinking. And so it's some long conversations and discussions of this stuff.
Thank you.
That was a great question.
Yeah, I don't see any more questions. And we just have 2 minutes. I'd like, if I could ask a quick question and make a comment. First of all, again, I thank you for joining us. I think it was very helpful. And I want to know, for the people who are listening to this, I realize that they may be thinking about this for their children, and confusion, a lot of confusion. And I think that your talk has really helped clarify a lot of things. I want to make sure that our patients recognize that if you're confused or you're not sure what to do, that I ask you to call your pediatrician first. I mean, if you're not sure, even if it doesn't mean that's where you're going to go, we don't know. But I think that if you talk to any of your pediatricians, set up a conference, we can spend more time to just talk about what it is that your child is experiencing and what's happening at any age. We're happy to do that. So I want to make sure that people are aware of that. But then I'll ask Drew this question: at what point, let's say we have transgender children, at what age, is there a particular age that you think would be important for us to refer to you to start the conversations that you have in possible treatment?
So I like to see kids as young as possible. And it's not for treatment, but more just support and answering questions and getting to know someone. And we'll see them maybe once a year. It's sort of like if they have, something where they're seeing another sort of a specialist every year. And so that can be really helpful. We can keep them, connected to community, tell them about opportunities coming up, things like that. And so as young as possible is good for us. It's really hard for me when I first meet someone just as they're starting puberty and we're sitting there talking about puberty with them, because I can tell you my own experience. I would not have been able to talk about puberty at that age with someone I had just met. And I will say that definitely within your practice and most of the larger practices in the area, I am thrilled when I find out they don't want to start coming to see me for all of their primary care, because it means they've got someone who's supporting them. And that is wonderful, because it's not the case everywhere. And I know that at NAP it is.
Great, thank you. Well, I think that wraps it up. Again, I thank you for joining us, everybody. Next, I just want to put in a mention that our next workshop will be November 12th, and we'll be talking about attention deficit hyperactivity disorder and behavioral management. So if you're interested, please join us then. Again, thanks everybody for joining us, and have a good evening.